Hey, good afternoon. My name is Betty. I would like to thank the Cancer Institute New South Wales for giving me this opportunity to present here. And I'm representing our team to talk about our streamlined rapid access to colonoscopy via our public hospital fecal occult blood test clinic. Our team, Professor Michael Berg is the Director of GI Endoscopy at Westmead Hospital, and he is our project lead, and Dr. Nicholas Burgess is the consultant gastroenterologist overseeing the FOBT clinic. And Betty Lowe is myself, and other members of the team help with the initial setting up of the clinic and contribute to the ongoing research projects. As you may know, colorectal cancer is the second leading cause of cancer-related mortality in the developed world, and up to 90% of bowel cancer can be successfully treated and cured if detected early. Large population-based randomized controlled trials confirm that fecal occult blood test screening, colonoscopy, and polypectomy reduce the incidence and mortality of colorectal cancer. The National Bowel Cancer Screening Program invites Australians aged over 50 to screen for bowel cancer using a free simple test at home, and the program was introduced or implemented at 2006. The program is expanding at different stages from 2015 to include more age groups, and by 2020, all Australians aged between 50 and 74 years of age will be offered free screening every 2 years. So with the expansion of the program, we could see an increase in the number of screening referrals. Currently in New South Wales public hospitals, Westmead Hospital being one of them, the majority of the model is patients with a positive FOBT result are referred to the general gastroenterology outpatient clinic, which has a significant waiting period. Consequently, there are substantial delays in accessing colonoscopy. We aim to reduce delays in clinical assessment, to improve the timeliness of colonoscopy, to increase the volume of screening referrals, and to increase compliance with colonoscopy. Hence the initiation of this project. I would like to acknowledge the one-year Cancer Institute New South Wales grant for providing funding for this project. We have set up a nurse-led public hospital outpatient clinic supervised by a consultant gastroenterologist. Referral criteria are asymptomatic patients who have positive FOBT results, either from the National Bowel Cancer Screening Program or GP-initiated or self-initiated. They will be assessed by the clinic nurse for colonoscopy. The consent will be done with the gastroenterologist. Patients with positive fecal occult blood test results are notified by the National Bowel Cancer Screening Program and are advised to visit their GPs. The GP either refers their patient to see a private gastroenterologist or refers them to a public system. To refer the patient to this new rapid access clinic, the GP can download a referral form from the Westmead Hospital's GI Endoscopy department webpage and fax through the details with their relevant result to a direct fax number or email. The referral form can also be obtained from our Medicare local Wentworth Health Pathways webpage. This rapid access clinic operates weekly and provides rapid triage, aiming to see patients at the clinic within 30 days after referral triage and complete a colonoscopy within 30 days after the clinic assessment. Our endoscopists perform procedures mainly in Westmead Hospital, and we also have 2 lists a week in Auburn Hospital's operating suites. We held a GP education evening to promote our clinic, and patients are given education on bowel preparation and advice on diet modification and adjustment of medications such as diabetic medications and blood thinners. They were also given a direct contact phone number for any further questions leading up to the procedure. This clinic reduces the burden on the general GE outpatient clinic by giving referrer feedback of results and recommendations, avoiding unnecessary follow-up in outpatient clinic, and free up more clinic slots for other referrals. Patients are also offered the chance of participating in 2 clinical studies, and quality metrics are captured and recorded for analysis. The clinic commenced in September 2015, and until January 2016, patients were seen as part of the regular Wednesday GE clinic, and from January onwards, patients have been seen in a separate dedicated FOBT clinic. From September 2015 to July 2016, we have seen 165 patients at the clinic. We have received 12 inappropriate referrals. A total of 4 patients declined having a colonoscopy, and we have informed their GPs to follow them up. 2 patients have procedure done privately after their clinic appointments. There were 21 colonoscopies pending at the time of analysis. This is one of the patient's journey at this clinic. AX, a 59-year-old male, change in bowel habits, was asked to have fecal occult blood test by the GP. He's not aware of any blood in the stool, no family history of colorectal cancer. Previous colonoscopy in 2010 found a 3 millimeter small polyp at sigmoid colon, and he was advised to have a colonoscopy in 5 years. He actually did not need to have a fecal occult blood test performed in the first place. He has a history of hypertension, high cholesterol, gallstone, fatty liver, emphysema, and medications are Crestor, Mycardis, Ventolin, and Spiriva. Time from triage to clinic is 17 days. Clinic to colonoscopy, 25 days. And from positive FOBT to colonoscopy, it took a total of 45 days. 6 millimeter sessile sigmoid polyp was found and cold snared. It is a tubular adenoma with low-grade dysplasia. Follow-up letters was faxed directly to the GP. Advice is to repeat colonoscopy in 5 years. There is no need to follow up in the general GE clinic. At the end of July, 126 patients has procedure completed. Meantime from triage to clinic and meantime from clinic to colonoscopy, both can be achieved within 30 days, which is our hospital's KPI. Prior to the institution of this clinic, meantime from clinic to colonoscopy is 40.5 days. Adenoma detection rate is 47.5%, and 4% of the patients were found to have colorectal cancer. Prior to the institution of the clinic, 74% of patients were reviewed again in the GE clinic, and this was reduced to 34% post-FOBT clinic, and 2/3 of these 34% for the review of the gastroscopy result only. Investing time in patients' education reduces unnecessary cancellation of procedures due to unpreparedness, and there are low rates of repeat procedures due to ineffective of bowel preparation. We compare data to the previous year. The blue ones you've seen were before the clinic established. We have not done so badly with 8% inadequate or poor preps. However, we can still have see the room for improvement in this area and have reduced to 2.5%. And the excellent or good preps come up from 73% to 86%. A direct number is given to all patients for inquiries about their preparation. However, I do call those whom I think might have trouble understanding the instruction a week before the procedure. This is a not so straightforward case. JB, also a 59-year-old male, fecal occult blood test positive from the National Bowel Cancer Screening Program. He noticed small amount of fresh blood at times. Also had mild dyspepsia, otherwise no other symptoms. No family history of colorectal cancer. He has history of hypertension and gout, and he took Cofazole and Pro-Gout. We were able to arrange gastroscopy and colonoscopy 27 days after the clinic. He did not arrive for the initial appointment. We contacted the patient immediately on that day and realized he had been hospitalized for acute MI 2 days prior to the procedure, and he hasn't had a bowel prep yet. We liaised with the cardiology team to have endoscopy done 2 months after the initial stabilization of his cardiac condition with a bare metal stent, and he proceeded to have the insertion of drug-eluting stent after endoscopy as planned. Endoscopy finding is moderate chronic gastritis, and he has a normal colonoscopy. The advice is to follow up GE clinic for his gastroscopy findings. Colonoscopy advice is to continue to participate in the National Bowel Cancer Screening Program. So from triage to a triage of referral to colonoscopy, it took a total of just over 4 months. We do track the patient. If they cancel appointments or they did not arrive for procedures, we reschedule the appointments accordingly. We also notice around 40% of the patient in the clinic speaks Cantonese or Mandarin and do need interpreters. So we have the bowel preparation instruction sheets translated in simplified Chinese and traditional Chinese for their better understanding of the instructions. To summarize, implementation of a new rapid access FOBT clinic has resulted in increased referrals to the GE department and improved access to rapid endoscopy for FOBT patients. Triage and clinic to colonoscopy target met, which is our hospital's target. Endoscopy exceeding quality KPI, again, is our hospital's KPI. Randomized control trials research done and reduced burden on GE outpatient clinics. And direct feedbacks for referrers, new resources for patients, fewer incomplete preps. In the future, we are looking at expanding education campaign, develop a e-referral, having same clinic implemented in other hospitals at our local health district, and eventually publication of randomized control trials. Thank you for listening.